So our standard plan is 2 pterygids, 2 anterior, 2 is premolar area, nasomaxillary buttress targeting the maxillaries. If we can find some good bone in molar area, we can avoid pterygid and we can place one implant in the molar area. So you can see the sinus. The sinus is not expanded distally. That is a good thing. Here comparatively more anterior expansion, mesial expansion, and here downward expansion. But still, pterygid is safer. Tuberosity is safer. You can see, no, this is a pterygid junction, but the tuberosity is very much down. But here, this is a pterygid junction. The tuberosity is a decent level. So here you can see. Even if you see, no, the level is good here, but here it is down. So better if we are planning for pterygid, we have to do tuberosity reduction. This is the tuberosity reduction. Okay. So we will plan the anteriors. Then we will see the canal first. So what is this canal shape? What is the canal shape?
Funnel.
This is cylindrical. Okay. Funnel means in the crest it will be very wide.
Okay.
So both the walls are parallel. No? So mostly it is cylindrical. You don't have to be worried about this thing. Okay, whether it is funnel.
So there it will be always narrow.
Huh?
At the start it will be always narrow.
Here?
At the start.
Yes. This is in the 1-1 area. The bone is less only, it's not very great. The crustally thickness is about 3 mm. So here we cannot place a 3 mm implant here, 3.5 implant here. The implant will be without bone and buccal and parapet side. So what you have to do is, we have to do the parallel approach.
Okay.
So that about 3 mm of bone will be on the labial aspect, 0 mm bone on the parietal aspect. The parietal soft tissue will protect them. About 13.5 length is there. Make sure we have to be away from the canal. You can see here it is opening as 2 foramens exit. Okay. So parietal approach is what save us. Here also same. Parietal you are telling, and nasal floor is 1700, which is very good. 13 mm is very good. You don't have to do any alveoplasty. And we plan for the buttress, nasomaxillary buttress or training buttress. So we will start from the as usual, first premolar or second premolar area and drill them easily. We start the drilling from the crest or from the mid crest or the parietal crest. Okay. Here also around 13 mm. So we will open the flap. We will expose the nasomaxillary buttress, the lateral nasal wall, and we will top like this. This side. Here we can use this 3D deformed image as a hammer. Here the bone is much better than the left side.
Right
side. Here the sinus is favorable. See, even if you have kept the implant away from the buttress, you are in good bone. That is actually a good thing. So we will keep the buttress and we will see. Okay? This also good. So this kind of long four. Two central.
Two nasomaxillary buttress.
This corner we are targeting. Behind this implant can be placed an implant. That's what we are going to check. A short implant we can place. Right? A short implant means around 10 mm we can place. 10 mm or 8 mm. Okay.
Sir, compressive implant or tip வந்து narrow தானே சார் இருக்கும்.
Yes, yes.
Here the bone is also narrow, no sir.
Yes, we can,
So
yes, we can part
can
it like
engage,
this. Yes, yes. We can increase the length. We can increase it. If you want to do like that, you have to drill along the labial wall. You should not angle it
Through sinus.
Yes. So you can place a little 1 mm or 3 mm longer. So this is almost near the molar area. And we will place one more implant here. Here we can place a short implant. So this is one option. So we are not going pterygoid at all. And we can give one tooth cantilever here since we are going for a bar and gluten restriction. So this will be a much easier plan for the lab technician designing for the surgeon everybody. If you want another option, you have to go for straightly pterygoid. Okay. So right side pterygoid is much. Even if you are not doing pterygoid, in front of the pterygoid also a lot of good bones. We can place a little longer implant and we can avoid cantilever without affecting the angulation. If you go for pterygoid, long interimplant distance will come. Of course, there is not a problem with the sclerotic distribution. Here, even left side, even if you are not placing pterygoid, you can place the implant anterior to pterygoid. Okay. We can avoid this short implant and we can place this implant. See, if you want to catch pterygoid, we have to go more distally and angulate it. Right?
Yes.
Otherwise, we can start drilling anteriorly, make it more vertical over a short implant, not longer as pterygoid. You can place a 13 mm very comfortably. So for designing milling, it will be a much comfortable option. So both sides, instead of pterygoid, we'll be placing a
molar implants.
Molar, almost like a second molar implant. You can call it as a second molar implant. The correct term is palatal bone. Engaging the palatal bone. 4.2 to 13 we can place, even if you do alveoplasty. About 3 mm we can do.
In Moyes book I read, sir, they say that even if it is in cantilever, we should follow a principle of anterior posterior diameter plus
Spread and
AP spread. Yes.
Many times we violate this AP spread dial. Since you are using titanium bar, you have more freedom. Okay. There, the metal used is different, chrome cobalt. Okay. But titanium is different property than chrome cobalt.
Due to its flexibility.
The one thing is, its weight is very much less. So by gravity, that problem is less. The other thing is, the properties of titanium bar is similar to the bone properties. So force distribution is very much better. So the key point is the titanium bar, splinting the implant with titanium bar. So we will, I feel this is a better approach than placing short implant here, giving cantilever. We can place a second premolar implant, and to improvise the plan, what we can do is we can tilt this, we can move this implant slightly distally, because the sinus is favorable, and we are avoiding this inter implant distance, and it's a good spread rather than packing all the implants in the anterior, and we will see whether we can tilt this implant still more distally. There is no big advantage in tilting this. This is from almost second premolar. We will place from first premolar.